Welcome back to the Ninja Nerd Podcast. We got a video podcast.
I know, it's pretty cool, man.
This is so cool.
Yeah.
We're changing it up a little bit. We're going to maintain our other audio podcast. You'll still find us on Spotify, Apple, all that good stuff. But we are doing a video podcast courtesy of Zach. This was his idea.
Oh, this is the hip thing to do. You know, everybody's doing it now. I was like, we got to do it too.
It's honestly, it's super fun.
Yeah.
We got 3 cameras set up.
Yeah.
We got everything ready to go. And we're really excited because we're just going to keep doing more and more podcast episodes on clinical medicine, everything you can possibly think of. But the coolest thing is that we're hoping to actually have live guests here. So clinicians, doctors, nurses, you name it, going through diseases, figuring out how they might approach it, and then kind of get a really good learning experience.
Yeah, I think that's one of the coolest things is, I see certain patient populations, but I may be very green and naive to a lot of other patients who that's when we bring in experts in the field to deal with this on a daily basis, and they can give us more of a clinical outlook in their opinion. And I think that's going to be really cool.
It's going to be a lot of fun. So today we're going to start it off, though, with volume disorders. So we're kind of just, what you'll notice is that if we're working on a topic for every other thing we're doing. So we might be working on volume disorders because we're doing it for YouTube.
Exactly.
We're maybe making it for our courses we're developing.
Yep.
We're trying to do it so that once we hit something, we kind of are all encompassing everything.
Yeah, and like if you want to learn about volume disorders, hypo and hypervolemia, you have the opportunity to learn from different avenues. If you're an aesthetic learner and you have to write things down, we have illustrations. If you want to see it visually and you have to kind of go through the videos, you'll have the videos. If you're an audio learner, you can have the podcast. And if you want to see our faces, you can have the video podcast on YouTube. So we're going to have a lot of different ways that we do this. If you want to do questions, we have questions. And if you want case series to see clinical applications, we're going to have all of that. And I think that just allows for you to learn one topic from multiple different avenues and help you to make sure that it stays in the brain, helps you for your exams and to be a good clinician, hopefully.
So let's jump right in then. We're going to be like Zach just said, we're talking about hypovolemia, hypervolemia.
Yep.
We're going to start it off with case 1, 2 cases. The first one's going to be on hypovolemia. So we're going to go through kind of a clinical vignette, and then we're going to learn about overall the overarching themes of hypovolemia and kind of talk about our patient case here.
Yeah.
So first thing here, we have a 24-year-old female presents to the emergency department with a 2-day history of severe watery diarrhea and vomiting. She reports returning from a camping trip 3 days ago where she may have consumed contaminated water. She has been unable to keep fluids down and she feels lightheaded upon standing. Her past medical history is unremarkable and she takes no meds. All right, Zach, so based on the history in this vignette, what is the most likely cause of her hypovolemia? And then like we talked about before, we have to know all about hypovolemia as a whole, not just what's going on with her.
Yeah, exactly. That's a perfect setup. And I think one of the things for this is this is a perfect clinical scenario where it's like the history tells you everything. And I love that when you can get that. Sometimes it's not always that easy in the clinical setting. But for this patient, it's definitely a GI loss. So she's losing fluid. The route that she's losing it is probably from both ends. So she's, pooping like a goose. And on top of that, she's vomiting like an exorcist. So that's going to cause a lot of volume losses, probably a lot of electrolyte kind of like abnormalities as well. That's definitely going to be her likely cause. And then on top of that, not only is she having diarrhea and vomiting, but she's not taking in an adequate amount of fluid intake from, food as well as drinking water, etc. So I think that would likely be her cause. With that being said, when we think about a hypovolemic patient, think about not just GI losses, are they having vomiting, diarrhea, poor PO intake, but also do they have like a bowel obstruction? Bowel obstruction patients, the same kind of thing. They have an NG tube in to kind of decompress the bowel, that they can suck off a lot of that fluid, and it's just a similar kind of a situation in vomiting. And so that would be another thing. I think renal losses is a really big one. So don't forget about the patient who is on diuretics. Maybe they're on that because they have some edema in their legs. Maybe they have underlying CHF, they have CKD, and they're on diuretics, but they're abusing it and they're not keeping up with some adequate intake. That can lead to some unnecessary renal losses. So look for loop diuretics, thiazide diuretics in their history. Another one, it's an insidious one. It's not as obvious in the history, but if I see a diabetic, I want to be thinking, could they have osmotic diuresis? So in a patient who's a diabetic and their glucose is really high, it can cause a lot of polyuria. So they lose a lot of water in their urine, and that can definitely cause dehydration. So think about that. Check the patient's glucose. Look to see if they're staying in control with their diabetes. The last one, it's a nuanced one, but think about this in the critically ill patient who has ICP issues and they just got mannitol, and all of a sudden their volume depleted, but they've peed out such large volumes of fluid. That's another one to think about is in that scenario. So if it's not losing it from the kidneys, losing it from the GIT, the other one I would think is, are you third spacing the fluid? This one's not as easy. It's more insidious, but I think the clinical scenario will kind of lay to it. If a patient comes in, they have pancreatitis, they can have massive epigastric abdominal pain and a lipase 3 times the upper limit of normal. But if I also notice that their volume depleted, sometimes what happens is they have so much inflammation that fluid leaks into their tissue spaces, and they can have edema and be depleted intravascularly. So that's one. And the same thing similar to that is a systemic inflammation due to an infection, like sepsis. So septic shock patients. So if they have like a leukocytosis, they have also fevers, they have hypotension, lactate elevations. And on top of that, their vascular system is low. It's because the capillaries are so leaky and they're leaking fluid out into the tissue spaces. So that's the things I would think about: third spacing, renal losses, and then GI losses as a cause. It's hers, obviously it's GI.
Yeah, unfortunately, GI losses, and she's having the poops pretty bad.
Yeah.
She's vomiting real bad. So
Yeah.
Unfortunate, but that's how it's just how it goes.
Yeah.
So let's move into the next part of this case, which is now looking at what are we looking at as far as lab findings, understanding if we get some blood work, what can we see coming back from that blood work, and just getting her vitals.
Yeah. I think that's a good point as well, because that gives a good overall clinical picture for the patient, like vitals, physical exam, and lab findings, if we have any.
So let's go through it. We have vitals here. We have blood pressure is 90/60, heart rate is 110, respiratory rate is 20, and her temp is 37 Celsius. Physical exam, the patient appears lethargic, has dry oral mucosa, and decreased skin turgor. Abdominal exam reveals diffuse tenderness and active bowel sounds. Cardio exam shows tachycardia with a normal S1 and S2 with no murmurs, rubs, or gallops. The patient exhibits orthostatic hypotension. Now for her lab testing. So we get a full blood work exam and we get a couple things back. Serum sodium is 133. Serum potassium is 3. Serum creatinine is 1.8. Her baseline was 0.9.
Okay.
BUN, 30. Bicarb is 19. Anion gap is 12. And her lactate is 3.2.
She's got a lot going on.
Yeah, that's a lot of stuff going on. A lot of things to kind of try and sift through here.
Exactly.
So, Zach, given the above findings, given the physical exam, everything we know about the patient, what complications is she actually experiencing? And what are some common complications of hypovolemia? Also, can you really highlight some buzzword terms, some big things that jump out in her history that's just screaming hypovolemia?
Yeah, absolutely. So the first thing is, like we started off with, the GI losses. That's likely her cause of hypovolemia. The complications, the clinical presentation of hypovolemia, this would be the perfect exam question type of patient. And the reason why is she has every single complication a hypovolemic patient could have. So first thing is she's hypovolemic to the point where her blood pressure is low. So her vascular system is depleted. She has decreased blood volume. We know that blood volume, if you have reduced blood volume, you have reduced stroke volume, because you don't have good preload, your blood pressure drops. So that's why she has hypotension. I would actually kind of say that she's more of like a hypovolemic shock kind of patient. The other thing is her heart rate's high, 110. It's telling me that she's having a compensatory tachycardia. So that's one of the big things, is if your blood pressure goes down, it triggers a reflexive tachycardia. So hypotension, tachycardia tells me that she's got some hypovolemic shock things going on. The fact that her temp is normal, her respiratory rate's normal, that's kind of good signs. Lends to me that she may not have any kind of like significant evidence of like sepsis. And also her history tells me that she's not likely septic. The other thing is her physical exam. So I would say that this is great for the exam, but I would say it's not always clinically applicable. And this is whenever you look and they say they have dry oral mucosa. So you look and their tongue looks like it's fissured and cracked all over the place. They have decreased skin turgor. So you pinch on their skin, you pull it up and you let go and it just stays like it's tinted up. That's evidence potentially that they could be hypovolemic, especially on your exam. The abdominal exam doesn't really give me anything about her hypovolemia. It just helps me to also assess that she may have an underlying cause of hypovolemia. The fact that she's tender may kind of render me to think that she has a gastroenteritis, especially with her vomiting and diarrhea. The tachycardia, again, adds to this picture. And the orthostatic hypotension, the fact that she said that she gets dizzy when she stands up abruptly, tells me that she's having a poor venous return to her heart, a poor cardiac output, poor brain perfusion, because her blood pressure is low because her volume's low.
Now, in a real clinical setting, is this pretty common, or are we looking at a pretty clear-cut case here?
I would say that the hypotension, tachycardia is very, very common. Orthostasis also could be relatively common. I'd say the dry oral mucosa, the decreased skin turgor, that's not always as perfect to be able to pick out. But The other thing that really tells me that's pretty common is the sodium. So when I look at the sodium that you said that her sodium is 133, she's losing not just like fluid from her GIT, from vomiting, diarrhea, not taking things in, not water only, she's losing sodium and probably even some degree of potassium, since her potassium is 3.0. So that's telling me that she has a hypovolemic hyponatremia, which is also common. And the big thing here that's kind of nerve-wracking is her creatinine is 1.8. Yep. Her baseline is 0.9. She doubled her creatinine. That tells me that she has an AKI, an acute kidney injury, because of poor renal perfusion, secondary to her hypovolemia from vomiting and shatting like a goose. Okay. So that's what's concerning. She's got AKI, hypotension, tachycardia, and then on top of that, hypovolemic hyponatremia. The last thing I would say is this is also really helpful, is that her bicarb was 19. So she's got a little bit of a metabolic acidosis. Her anion gap's right on the verge, but her lactate's 3.2. So her lactate being elevated is probably driving her metabolic acidosis. And lactic acidosis is a feature of poor tissue perfusion in the scenario of hypotension, especially given her hypotension is driven by hypovolemia. So she's got hypotension, tachycardia, lactic acidosis that is a kind of reflective of that, an AKI, and she's also got hypovolemic hyponatremia. I would say she has every single possible complication of hypovolemia. The only other thing is that I see here that she's lethargic. Sometimes when your blood pressure is really low, you don't perfuse the brain, and you can also develop an altered mental status. That's a little bit more tough to pick out in certain patient populations, but I think that she has the perfect picture of hypovolemia here.
So a lot of things going on here. Hopefully we can get the treatment figured out now and understand that, she's losing a lot of fluids from her GIT, whether it's, vomiting or the shats.
Yeah.
Now we get to treat it. And I'm hoping it's pretty straightforward.
I think for her, it's pretty straightforward. Like right now she has diarrhea, she has vomiting. We can do our best to try to minimize that with certain medications. We have to be careful because if she has a gastroenteritis that's due to an infectious etiology, like Shigella, E. coli, or C. diff or something like that, I think that's unlikely, but you don't want to kind of keep that bacteria sitting within the colon if you give them like antidiarrheals. So we're going to have to kind of give them supportive care for the moment and try to replace the volume that she's losing. And the best way to do that is to give her fluids. Now, how would we start off with doing this is the question, because I think a lot of the times these patients may get a little bit fluid overloaded, which leads us into the next conversation, hypervolemia. But I think the big thing is if I have a patient who's vomiting, diarrhea, they're not taking in things, and they have hypotension, acute kidney injury, they also have tachycardia and lactate elevations, I'm going to start off with maybe 1 to 2 liters of isotonic crystalloid solutions. What would that be? Normal saline, lactated ringers are going to be the choice of that, agent there. Albumin, which is a colloid, is rarely ever going to be an answer. It has adverse drug reactions. It's not that great of a drug unless you have underlying liver dysfunction like cirrhosis or nephrotic syndrome. So don't give albumin. If you're going to give it, start off with maybe 1 to 2 liters of normal saline or LR. From there, here's what you have to remember. When you give these fluids, you have to be monitoring particular things. And that is so extremely, extremely important. And we'll talk about that in a second. Other things that I would consider is after I've resuscitated the patient with maybe 1 to 2 liters of fluid, the next thing I would also consider is, do I need to put them on some kind of like maintenance fluid? And those are going to be other types of solutions, such as like half normal saline, which is a very common one, or even something like D5W. And we'll talk about that next as well.
All right, so back to our patient now. What fluid would you administer to her, and why would you be doing that?
Okay. So I would start off, like we said, isotonic crystalloid. I would give her maybe 1 to 2 liters of normal saline or LR. The reason why I'm going to do that is I'm going to fix the complications that she's experiencing. So she has hypotension. I'm going to give her the fluid, hopefully improve her blood pressure. She has tachycardia. As I improve her volume status, hopefully her blood pressure will improve and her tachycardia will reduce. The other thing that I'm going for is the acute kidney injury. So her creatinine's up and her urine output's probably trailing off because of that. So I'm going to give her fluid and keep a very close eye on her urine output to see if her creatinine starts coming down and her urine output starts going up. And the last thing is I would check her lactate levels to say, hey, are we perfusing the tissues a little bit better as the blood pressure is improving? And I would look to see, is her lactate kind of normalizing? And those are the ways that I would try to be monitoring the patient as well as treating them with the resuscitation. So after I've resuscitated them, that's when I would step back and say, okay, I shouldn't really give them any more boluses of fluid, meaning I won't give them like large volumes quickly. Then I would step back and I would say, are they still losing fluids from their GIT? Are they still having vomiting, diarrhea? They're not taking in as much like oral hydration and food. That's when I would say, okay, let me put them on a maintenance fluid. That's when you can do normal saline. You can still do LR, or you could do half normal saline, but I would do it like maybe 1 cc per kilogram of body weight. So if they weighed 70 kilograms, I would give them 70 milliliters of normal saline or LR, half normal saline. And I would use that until they have improvement of diarrhea, improvement of vomiting, and they start taking in food and fluids. And then from there, boom, cut the fluids, no more. We've treated their causes, we've treated their complications, and we've allowed for them to improve, get back to drinking and eating on their own, no more fluids. So that's how I kind of go about doing that, if that makes sense.
Yeah, makes perfect sense. And in fact, we've wrapped up hypovolemia.
Exactly.
Not too bad.
All right, cool.
So let's move right into case 2, which is hypervolemia.
All right.
We have a 58-year-old male with a history of type 2 diabetes, hypertension, and CHF. In fact, his left ventricular ejection fraction was around 35%, so not very good.
No.
He presents to the clinic complaining of increased shortness of breath, especially at night, and swelling in his legs that has worsened over the past 2 weeks. He reports adherence to his medication regimen, which includes metformin, lisinopril, and amlodipine. The patient mentions he has been drinking more fluids lately because he read on the health blog that it might help with his frequent leg cramps.
Okay. Good old Google.
Right? Yeah, Google, scrolling Facebook, These aren't peer reviewed.
Yeah, exactly.
So Zach, based on this history and this clinical vignette, what is the likely cause of his hypervolemia?
Okay.
And then tell us a little bit more about the common causes of hypervolemia. Again, just not going into his case, but the whole hypervolemia.
Gotcha. All right. So I think the big thing for this guy is it's a twofold problem. And usually hypervolemia is caused by 2 pathophysiological concepts. One is excess fluid administration or excess fluid retention. He's got both. So he has underlying diseases that make him more susceptible to fluid retention, such as his heart failure with a reduced ejection fraction. He's got an EF of less than 50%. So he's got potentially some HFrEF, or systolic heart failure, we can call. In this particular situation, that makes him susceptible to retaining fluid. On top of that, he read on a blog that he should drink more fluids to improve his leg cramps. And we try to restrict heart failure patients to, keep them like less than 2 liters of like fluid per day. Keep an eye on their daily weights. He has excess fluid administration. He's going to retain that because of his underlying CHF. So he's going to retain and then take more. That likely tipped him over into the hypervolemic camp here. I think the common causes, to kind of go back to the 2 pathophysiological concepts. One is excessive fluid administration. Either you're drinking way too much water or too much sodium. That's a very common thing we see in the outpatient setting. Or you're getting intravenous fluid resuscitation, which is a very common iatrogenic harm that we see in hospitals and ICU settings. Patients come in, they have hypovolemia, hypotension, and then they get just waterlogged with fluids. They get flogged with fluids for a couple of days. Before you know it, they came in 110 pounds, and now all of a sudden they weigh 140 pounds, and they look like the Michelin Man.
I was going to say they're blown up.
Yeah, exactly. So that's a very common kind of offender. The other one is, again, your fluid retention causes. Does the patient have CHF? CHF, especially with a reduced ejection fraction or severe diastolic dysfunction, puts you at risk of retaining fluid because anything which reduces your cardiac output activates the renin-angiotensin-aldosterone system and causes you to retain sodium and water. And on top of that, these patients have high pressures in their heart that fluid loves to back up into the lungs or back up into the lower extremities and even abdomen. The other one is CKD. CKD, they have very poor glomerular filtration rates, so bad that they have a hard time being able to excrete water, sodium, and other electrolytes out into the urine. And so those things can build up inside of the bloodstream. So in patients who have severe acute kidney injuries or their GFR is kind of really getting down to the point where it's like near like less than 20, they're near CKD4 or above, they're at high risk for fluid retention. And so that's a big one. The last one's cirrhotic patients. These are tough ones. Cirrhotic patients who have portal hypertension, they have a lot of splanchnic vasodilation because their pressure in the portal system's high. They release chemicals to dilate their portal vessels, but it pools blood in the splanchnic vessels to go to your GIT and takes blood away from the kidneys. The kidneys sense that. They say, hey, I'm not getting enough blood. Let me activate the renin-angiotensin-aldosterone system and retain more sodium, water, build up my blood volume and blood pressure so I better perfuse the kidneys. Problem is, all of that fluid that they retain starts leaking into their abdomen. It starts leaking into their legs. And so they get a lot of features of edema. So those are the big causes. But for this patient, it's heart failure and excess fluid retention or excess fluid administration.
Sure. Okay. So let's go ahead now and move into vitals, physical exam, and then some pertinent lab findings that we really have to talk about.
Okay.
So blood pressure, we have 172 over 88.
Woo-hoo.
Oh boy.
Yeah.
Heart rate is 88. Respiratory rate is 22. Temp is 36.8 Celsius, and his oxygen saturation is 94% on room air. For the actual exam, the patient appears to be in no acute distress, but has noticeable pitting edema up to the shins bilaterally.
Okay.
As we talked about, some CHF findings right there.
Yeah, exactly. Yeah.
Auscultation of the lungs reveal bibasilar crackles. Abdominal exam is significant for mild ascites. And cardio exam is notable for an S3 gallop.
All right.
Can you find an S3 gallop in real life, Zach?
Probably not. I would have to really like have one of those special stethoscopes, and even then I'd be like, yeah, it sounds good.
I would need like a digital one that like tells me, because I don't know how you can hear that.
That it takes a skilled cardiologist, I feel, to listen to a lot of hearts. You find the normal ones and like, this one's not normal.
Yeah, you just know.
yeah, exactly.
So initial lab testing now, we have the serum sodium is 138, potassium is 4.2, serum creatinine is 1.5 with a baseline of 0.8, BUN is 28, bicarb is 24, and we have a BNP level of 580.
Okay.
Chest x-ray reveals pulmonary vascular congestion in small bilateral pleural effusions. So given all of these findings, there's a lot of stuff going on.
Exactly.
There is a lot of stuff going on, but basically trying to break it down one by one, what are you kind of seeing here with complications, Zach?
Okay.
What are you seeing with things that are jumping out at you for this patient? And again, hypervolemia as a whole.
All right. So yeah, this person's, again, got every single possible perfect clinical picture of hypervolemia. Like, it's literally perfect. So for this patient, I would say right off the get-go, we know their cause is likely CHF with, taking too much water because they read it in a blog. But one of the big things here is that in patients who are hypervolemic, if you do keep somewhat more fluid inside of your vascular system to some degree, and you've overloaded your vascular system, it is very common for the blood pressure to go up. So hypertension can be a potential presentation. Now, keep that in mind. There is caveats. If a patient has acute heart failure, they may not have hypertension. If it's more of their chronic heart failure, chronic cirrhotics, chronic CKDers, or they have like an acute onset kind of like AKI, those are more likely to be hypertensive. But in the patients who have an acute like heart failure, they could be hypotensive. So it's not always perfect, but hypertension tells me they're a little bit volume overloaded. The other thing is the pitting edema. So that tells me that the central venous pressure of the right heart is a little bit high. And we can see this in heart failure, but we can see this in any other kind of volume overload state where the central venous pressure, the right heart pressure is high. So I'm going to say again, that's highlighting the fact that this person has peripheral edema. Then the fact that they have fluid in their lungs tells me that there's a left heart problem. The left atrial pressure, the left ventricular pressure is high. That lends to me that it's more likely a heart problem. So if I have a patient who has bibasilar crackles, it tells me that they likely have pulmonary edema, and their left atrial pressure is a little bit too high, and that's causing fluid to back up into the lungs. Another way that we can see this is that they can present, as this patient did, short of breath when they're laying flat or when they're sleeping. So paroxysmal nocturnal dyspnea, orthopnea. And in really bad cases, they can become hypoxic. Thankfully, this patient is not hypoxic. The ascites is also interesting that, again, if a patient has pitting edema, it's a high central venous pressure. If they have ascites, that's also high central venous pressure. You can see ascites in cirrhosis. You can also see this in CHF as well. More likely the right heart is starting to fail, but we can see this. And so they have ascites. That's telling me they have high central venous pressure. Bibasilar crackles, they have high left heart pressure, and pitting edema, high left heart pressure. The S3 gallop tells me that they're just volume overloaded. The ventricles are super dilated. They're very, very kind of stretched out and compliant. And that, again, lends to me that this patient has evidence of heart failure-related hypervolemia. So all of these things is the perfect picture. And then when you look at the lab testing, again, in this patient, serum creatinine went up. It's probably because they're fluid overloaded. And what happens is an interesting thing. When you have CHF, your cardiac output's kind of lower, and so you don't perfuse the kidneys, or at least the kidneys don't sense a good perfusion. But then your central venous pressure is high. And so your ability to drain blood out of the kidney is reduced. And so you end up with renal congestion. And we see this a lot in patients who are volume overloaded as a form of prerenal AKI. They have difficulty getting fluid into the kidney and difficulty getting fluid out of the kidney. And so this is a common one. The fact that the BNP is elevated, if it's usually greater than 400, it tells me that the cause of dyspnea could be due to heart failure, but it's not guaranteed. And then when I get the chest x-ray and I see that they got pulmonary edema, bilateral pleural effusions, it tells me that they have a lot of fluid in their lungs. So this patient has every single possible kind of like perfect clinical picture of hypervolemia. I think the only thing that they don't have is jugular venous distension. And I'm pretty sure that they probably just missed that on the exam. But otherwise, I would say that this is the perfect clinical picture. And really, any other complication that would be maybe not here is just that the patient may have some jugular venous distension. And if they check their weights, I would expect that their weights have been kind of going up over the past couple of days.
I was going to say this poor patient has every complication that could possibly happen.
Exactly.
They're having a rough go at it. But now we have to step in and say we have a really good picture of what's going on. How do we now treat this patient?
Yeah, so obviously every kind of disorder, you have to treat the underlying disease. Just like in hypovolemia, you have to stop their diarrhea, their vomiting, get them to start taking in food and fluids. But obviously in the interim, you have to support them. You have to give them fluids to replace the fluid that they lost. For hypervolemia, you have to treat the underlying cause. This patient needs to kind of reduce their fluid intake, and they need to treat their underlying CHF and improve their ejection fraction. But in the interim, while you're trying to fix those things, you have to strip fluid off of them. And that's where diuretics come into play. And so there is a bunch of different types of diuretics that could be instituted in this patient. The common diuretics that are given are loop diuretics like furosemide, bumetanide, torsemide. Other ones that can be also added in as an augmentation is your thiazide diuretics like HCTZ, chlorothiazide, metolazone. Another one that's commonly given in CHFers, and especially in patients who have cirrhosis, is your potassium-sparing diuretics like spironolactone, eplerenone. The last one, which is kind of a nuanced scenario, which we'll talk about, is your your carbonic anhydrase inhibitors, like acetazolamide. And this one has a very nuanced scenario where you can add this into the CHF as well. The last scenario that you could use for a patient to strip fluid off is hemodialysis. But I think it all kind of depends on the patient and how they respond. My first kind of like initial thing for a patient who's volume overloaded is to say, let's give them furosemide, so a loop diuretic. It's the most commonly utilized one. And I would say, let's give them maybe 40 milligrams of furosemide or 80 milligrams of furosemide and see how much volume we can pull off of them. And what's my goal? I'm doing it for particular reasons that we'll talk about in a second. I'm trying to pull fluid off to treat the underlying complications. So that's why I would kind of start off with first is give them a loop diuretic, see me start kind of pulling off fluid, and then I'll monitor if they're improving for that.
So I'm going to complicate our poor patient just a little bit more right now.
Okay.
So let's say he's on furosemide, like you said, it's the most common one.
Yep.
What happens, we're doing volume removal, what happens if you're starting to notice now hypernatremia and hypokalemia?
Oh, okay.
So what diuretics would you switch to in that situation?
Okay. So if I start removing volume, right, furosemide is going to block the ascending limit loop of Henle. It's going to block those sodium potassium 2-chloride cotransporters, cause a good amount of volume removal. But like Rob brought up, one of the complications that can happen is as you remove a lot of like water from the body, your sodium will start kind of rising. And then you're also going to be dumping a lot of potassium into the urine. So these are two common complications. I don't want to get complicated and say, okay, I'm going to give them sodium, I'm going to kind of do something where I got to give them more water to kind of bring their sodium down. So what I can do is, and I like this, is if I have to really remove volume, I'll start with a loop diuretic. Let's say that I start with 40 milligrams of furosemide and I want to pull some fluid off. I start noticing their sodium is coming up or it's trending upwards or they're already hypernatremic. I add in another diuretic. And here's what I would add on. I would add in the thiazide diuretics. I would add in something like hydrochlorothiazide, metolazone, chlorothiazide. The benefit of adding those in is that they're going to help to remove a little bit of volume as well, but also get rid of sodium. So that would treat the hypernatremia and also help me to get some volume off of the patient. The other one is if I have a patient who's starting to get hypokalemic, then I got to give them potassium. And then sometimes when you give potassium replacement, some of the other things that can happen is you give fluid with the potassium replacement in the hospital. And then you're kind of just, you're playing with problems here because you're trying to get fluid off and then you're adding fluid back into them. You can give oral potassium, which can help. But one thing I can actually do to reduce the desire to take in oral potassium is I can give them a potassium-sparing diuretic, which will pull off fluid. But if I give them something like spironolactone or eplerenone, it prevents potassium excretion to the urine and the potassium will start kind of coming back up. So I'll start off with a loop diuretic. As I start noticing hypernatremia or their sodium going up, add in a thiazide diuretic. If their potassium starts going down, I add in a potassium-sparing diuretic. And then that will treat those electrolyte abnormalities. The nuanced one that I brought up, Rob, is what if we add to the patient to make them even more complicated? What if their bicarb starts going up and they get a metabolic alkalosis? That's when I can add in a carbonic anhydrase like acetazolamide, and that will help to get bicarb out in the urine, and that'll bring their bicarb down as well. So it'll prevent their metabolic alkalosis. So those are the ways that I would go about a patient as loop diuretic. If sodium goes up, thiazide. Potassium comes down, potassium sparing diuretic. And if the bicarb goes up, add an acetazolamide. So that's kind of how I would do that.
All right. So let's just say you go through all this diuretic therapy. You've got a whole list of things you're doing, and you're kind of going down that stepwise approach.
Yep.
It's just not working. At what point do you consult nephrology?
That's a great question. So the goal of diuresing a patient is to treat their complications, right? So first thing I want to do is get the volume off, but the reason why I'm trying to do it is to bring their weight down. So I'm going to track their weight. Am I getting their weight off? Also, is their pulmonary edema improving? So are they less short of breath? Am I getting rid of some pleural effusions? Or is their kidneys, am I decongesting their kidneys and improving their renal function? So am I reducing their JVD, their ascites, their pitting edema? If I'm doing all those things, great, I can stop my diuresis. But what if I have to continue, like you said, and I'm just not able to get their pitting edema down? I'm not able to get their weight down. I'm not able to treat their pulmonary edema, their blood pressure, getting that down. And I'm running into a lot of electrolyte disarray as I'm trying to diurese them off. Or worst case scenario, their kidneys just stop working. That's when I would say, okay, I'm going to reach to nephrology and say, hey, I have a patient who is volume overloaded. I can't get the volume off of them. I've tried everything. I've tried all the diuretics possible. Or, hey, their kidneys are not working and they're not even responding to diuretic therapy anymore, so it's useless. I need to reach out to them for them to help me to begin dialysis, to have a temporary time period where their kidneys can improve, we can get the volume off, and then get back to them kind of their normal life. So that's kind of when I would reach to that. Other indications for dialysis is the AEIOU, so it's refractory acidosis, electrolyte abnormalities like hypervolemia, toxic congestions, which isn't relevant here, overload, which is the common scenario here from volume, and then uremia. So those are the scenarios where I would consider dialysis. But for this patient, it's just I can't get the volume off, or their kidneys are stopping making urine, and my diuretics aren't working anymore.
There it is. So we have finished our very first video podcast. That's it. There's 2 cases, hypo and hypervolemia. We're done.
That was cool.
Nailed it.
That was awesome, dude. That was awesome. It was way more fun. Yeah.
Well, it's a lot more fun with the cameras, but again, just in case you're driving or something, you'll still have Spotify, whatever you want to watch, listen to.
Yep.
But we're going to keep doing this. Hopefully, it's going to be a Friday thing for us. So every Friday we'll release a podcast.
Yep.
Hopefully a live case series. So keep updated on YouTube.
Yeah, baby.
We'll have live case series, a lot more interactive, a lot more fun things that we can kind of follow and learn from.
Exactly. But this has been fun, man. I enjoyed this.
This has been awesome. Yeah. So Zach, give us our classic send-off.
Well, Ninja Nerds, thank you guys so much for listening to this podcast. I hope that you guys liked it. I hope that you guys enjoyed it and learned a lot. I love you. Thank you guys. And as always, until next time.